The Woodrow Wilson Center. My name's Kent Hughes. I run a program here on science, technology, America, and the global economy, and work very closely with the Global Health Initiative, which is hosting today's event. Let me tell you just a bit about the Woodrow Wilson Center for those of you who are new. The Woodrow Wilson Center was established in 1968 as a living memorial to Woodrow Wilson. As you may know, Wilson was the only president to have earned a PhD. That in his era, he was quite a prominent political scientist. Went on, of course, to become governor of New Jersey and then president of the United States for 2 terms. He often commented that because of his academic background, his work on policy, he really was a more effective policy maker. And he thought that had he been more exposed to the real world of politics, it would have enriched his research a great deal. So that is, in a sense, the mission that the Congress gave us, to bring together the top thinkers, the kind of people we have on the panel today, together with people who are themselves top thinkers but are very much engaged in the fray of making policy or part of the Washington, in this case, Washington policy community. We don't advocate. What we try to do is to clarify the choices before the policy community, add a different perspective, draw their attention to new ideas. As I mentioned, this session is being hosted by the Global Health Initiative, which is a relatively new initiative here, started in 2005, to really focus on the key global health questions that are increasingly part of the list of 21st century questions to deal with. I want to take just a second for a little advertising. Those of you who are interested in global health, beyond the questions of work stress and so forth, we have 3 more events under the Global Health umbrella coming up. Tomorrow from 2 to 3:30, Yohei Sasakawa, chairman of the Nippon Foundation, will be speaking on the question of leprosy and human rights. On Monday, March 10th, from 2 to 5, the Global Health Initiative, in conjunction with our Division of U.S. Studies, is looking at ethical decision-making at the end of life. And then on March 12th, Wednesday, 3 to 5, we have researchers from the Initiative for Maternal Mortality Program Assessment. They're going to be talking about how to reduce maternal mortality in the developing world. Well, today we have a very interesting presentation that in many ways most of us will think is something that we cope with all the time, which is work stress and its impact on health. The panel here is really going to step beyond that kind of everyday water cooler discussion. They are all contributors to unhealthy work, causes, consequences, and cures. And instead of the more casual conversations that we have, they're presenting in the book a 3-part approach in which they look at the changes that have come in working life here and around the world. They have a scientific basis to measure the impact of those changes in terms of work stress and their consequence for what you might think of as a new set of epidemics: hypertension, diabetes, heart attack, stroke, that cluster of questions. And finally, they end the book by looking at a series of anecdotes, of specific examples that help illustrate and make more concrete the scientific data. Well, we have, as I suggested, a really absolutely outstanding panel here. Let me just mention them briefly. I think you do have their bios in front of you. To your left, far left, is Dr. Peter Schnall, who is a clinical professor of medicine at the University of California, Irvine. He's also director of the Center for Social Epidemiology. He's an adjunct professor at UCLA. And as with the other members of the panel, he's a contributing editor and contributing author to the Unhealthy Work book. Paul Landsbergis is an associate professor. He's just also to your left, but not quite as far. He's an associate professor in the Department of Community and Preventive Medicine at Mount Sinai School of Medicine. He, among many other duties, was a member of the National Research Council's Commission on the Health and Safety Needs of Older Workers, something that I plan to begin to take seriously in just a few years. And to his left, to your right, is Marnie Dobson, who's a research associate at the University of California at Irvine's Center for Occupational Environmental Health. She's published a number of articles in this field, and as I mentioned, is a contributor to the Unhealthy Work book. And to her left, and just a little bit to my right, is Ellen Rosskam, one of the Wilson Center's own. She's a Southeast Europe policy scholar at the Woodrow Wilson Center, and really especially in social policy and public health. She is a much published author and is a professor at the Work Environment Department at the University of Massachusetts Lowell. What we're going to have is an unusual panel in the sense that rather than a series of independent comments, we really have a group that is going to sing, or one might say speak, in four-part harmony. And there will be a little bit of going back and forth as they walk us through a detailed presentation, slide presentation. After the presentation, we are very fortunate to have with us Josh Bivens, who is an economist at the Economic Policy Institute. And you've been there since 2002, is that right, Josh? He has a distinguished background. He particularly distinguished. He worked as an economist at the Congressional Research Service. Since I'm an alumnus of that organization myself, I know what a fine background that is. He, as you may know, EPI does a lot of very good work looking at questions about what's happened with productivity growth and wage increases and why that gap has widened. They put out every other year, I believe, really the seminal book that explores those and other questions. Well, the way it's going to work, we have just about an hour-long presentation. In toto, each of the speakers will talk for about 15 minutes, and then we will turn for 15 minutes of commentary to Josh. And Peter, I believe you're going to start us off.
Ken, thanks very much for a wonderful introduction. My colleagues and I are delighted to be here. Thank you very much for coming today. We have an intricate story we want to share with you. We feel it's a story that hasn't been told enough and that it's important for people to hear, particularly for those of you who are concerned about health and policy and are working to do what you can to make things better for folks. We want to talk about the interrelationship of globalization, social inequality, and work. We are concerned that these two areas of life are not being examined carefully enough for their impact on the health of working people. And we start with the obvious observation that globalization has created enormous amounts of wealth, but we also want to point out the counterpart of this, which is that aggregate wealth does not describe what's happening on the individual level, that the data needs to be disaggregated. And so we also note that there's marked increases in social inequality around the world, that this inequality creates disparities in resources between communities and between nations, and also that the processes of globalization are creating enormous impacts on both the community and the work environments. And part of these impacts are obviously toxic exposures at the level of the physical environment, but also contributions to the work environment itself in terms of work conditions, both unsafe work conditions and work organization and psychosocial stressors. Our main points today, and I'm giving you just a brief overview, is that globalization is contributing to this changing nature of work, a changing nature of work which basically began with industrialization and capitalism back in the 18th century and which has continued for the last 200 years. And that globally this changing nature of work is contributing to poorer health of many peoples worldwide. We'll present data from industrialized countries relating working conditions to health outcomes. And we'll note that there is more data available from Western industrialized countries which have been collecting information on this to share with you. And we also want to point out that the United States is one of the few countries in which a national database relating work to health is not being collected. And we do not think that this is an accident or simply benign neglect. Data is inadequate to address a number of issues which we all might be concerned with, particularly changes in work organizations such as downsizing, mergers, outsourcing, offshoring, and informal labor sectors. We will present some anecdotal, limited studies that address these issues. A key point here is this notion of global epidemics as natural processes. They're not. They're not the natural results of aging. Rather, they are the products of industrialization, of globalization, of urbanization, and of chronic stress exposures. And the medical model explanations are inadequate to explain or contain these epidemics. And essential hypertension, which is a core part of our own interests, is a good example of this, since after 100 years of research, the etiology of this disease, which afflicts 950 million people worldwide, is still unknown. They're not caused by genes, these epidemics, nor by individual behaviors. They involve social causes, such as class differences, economic inequalities, and unhealthy working and living conditions. This is a basic thesis of our presentation this afternoon, and we will present evidence to support it. How does work contribute to these epidemics? These many changes which we'll describe today all contribute to chronic stress at work. And this exposure to stress is cumulative. And the cumulative impact, which leads to things like biological arousal or mental exhaustion, in turn leads to physical and mental illnesses. We would point out that the ubiquitous appearance of stress, so many people reporting stress worldwide, is evidence itself of the fact that it's a basic social process related to the way we've organized life in modern society. And that this process has its own social causes, which we will detail today. The counterpart, which is the traditional medical explanation of things, the focus in on individual behaviors, that somehow or another the person's responsible because they smoke or that they are overweight or they live an unhealthy lifestyle, we think obfuscates the issue, prevents the formation of a common language of social causation, truncates the model of causation from left to right by ignoring all the social and environmental contributions to these individual behaviors, and thereby basically obfuscating the issue of the etiology, cause, and cures of these problems. We also have a basic stance. We believe in a good society, and that the good society has a number of different features. I could go through each one of these individually. I don't think it's necessary. We'll touch on them during the presentation. But I would say that good working conditions, healthy work, is a critical aspect of a good society, and one that we should all be aspiring and working towards. Over the next hour, there will be 4 presentations. My colleague, Paul Landsbergis, is going to walk us through what we know about globalization, its impact in terms of social inequality and its effects on work. He'll turn the microphone back over to me, and I'll walk you through what we know about how work impacts on health, mostly looking at the Western industrial countries, but taking a peek at what's happening in China and elsewhere. Marnie Dobson, my colleague here on the left, will review the evidence linking work to mental illnesses and mental health outcomes, and talk a little bit about the costs associated, the enormous burden, productivity costs and health costs, and what those economic realities are. And finally, my colleague Ellen Rosskam will give you a presentation of our views of what's been done around the world in terms of cures, what social policies we either know about or we believe would be helpful in trying to prevent these global epidemics. And with that, I'd like to turn the presentation over to my colleague Paul Landsbergis, who will carry on with the globalization talk.
Thank you. Economic globalization over the past generation, we know, has included a lot of discussion of free trade. But we also know that there's a whole broader set of policies beyond free trade that make up the globalization agenda. Privatization, for example, the sale of state-owned industries, but in addition, privatizing government services. Another important policy has been deregulation. Not only deregulating capital markets, but more importantly for our talk today, deregulating labor markets, reducing the social protections that we've come to expect minimum wage laws, overtime laws, job safety and health laws, job security. And finally, a policy of reducing social welfare transfer payments to the population. And by that we mean, of course, Social Security, Medicare, and related programs. So this set of policies has impacted on our work through changes in the labor market and through changes in organizational practices. Let's look a little about what we've seen in changes in the labor market. Here from surveys from the European Union, we see large increases in the proportion of workers who are part-time or temporary, what are called precarious and contingent workers. We've also seen in the U.S. a large increase in income inequality since about 1970, an increase in the gap between richer and poorer. We've also seen in many developed countries a decline in the proportion of the workforce that are members of labor unions between 1970 and 2000. Although there are exceptions. We see that in Sweden and Finland there have been increases during this time. Interestingly, some new data covering the last 7 years suggests that worldwide the proportion of workers in unions is increasing. This is data from national labor federations around the world. And in fact, even in the United States, the proportion of workers in unions increased slightly in the past year. So perhaps we're seeing a change in this trend of decline in labor union strength. Privatization of healthcare services around the world has meant workforce reductions and worse working conditions for many healthcare workers. And this is described very well in a new book by the ILO, edited by Dr. Rosskam. These changes have meant worse quality of care for patients, as well as lower priorities for public health and disease prevention. And in general, the caring economy, education, health, and social services, we know that women are a majority of this workforce. And when government cuts its support for these types of programs, the work still has to be done. Children have to be taken care of, old people have to be taken care of, and we know who tends to absorb this burden of unpaid labor in the society. So, to this list of changes in the labor market that I've just mentioned, let me add one more important one: migration. Millions of people around the world moving to other countries or regions within their country to find better jobs. Now, what have organizational practices been? With deregulation, less social protection, weaker unions, employers have much greater latitude. They demand from us a lot more flexibility. And that flexibility can mean fewer employees in a workplace, downsizing. It can mean for the workers that remain in a workplace greater schedule flexibility, mandatory overtime, for example. Some of the changes in flexibility, such as teamwork or greater job involvement, multi-scaling, can be helpful to some, beneficial to some employees. But for most of us, still, job assignment and rotation depends on employers' needs. A prime example of this type of all these forms of flexibility is called lean production, or Japanese production management, the Toyota production system, and it involves a real intensification of labor. So in addition to these organizational practices, which I've just mentioned, we could add increasing electronic surveillance of workers, whether computer operators, call center workers, delivery truck drivers, who now are having their work monitored, causing increased stress. And, well, a traditional organizational practice, which is still in vogue, union avoidance. All these changes I've been describing reinforce each other. If you don't have job security, you'll work as hard as it takes to keep your job and perhaps get a more permanent job. And this tends to undermine the resistance of permanent workers to work intensification. If you can only get health insurance through your employer, if you don't expect to receive Social Security, if you can't expect to actually get the minimum wage because the law is not enforced, then these overriding pressures force workers to work harder and longer. Okay, all these changes affect the job characteristics, job demands, job control, work hours, that we know are related to our health. So let's look at some of the data on trends in job characteristics. First of all, in hours worked per year, we see that for the United States, over the past generation, on average, there's been not much change in total hours worked per year. But this is in sharp contrast to other developed countries who have taken their increased productivity and translated it into fewer work hours for their employees. So we are now number one in the developed world in work hours. Don't let anybody tell you we're not number one. But this average in the U.S. hides a multitude of sins. We see that for men and for women, there is an increasing proportion working more than 50 hours a week, and an increasing proportion working less than 30 hours a week. So an increase in both overwork and underemployment. This work hour average also only includes people in the paid labor force, and we know that a lot of people have been entering the paid labor force in the past generation, mostly women. So if we look at total family hours worked, husbands and wives with children worked, we see that the total number of hours has increased by about 20% over the last generation, increasing the stress on families to juggle their time and make ends meet. Sorry about that. Okay. One of the reasons for this, for these high levels of work hours in the United States is that we are the only country in the developed world without any legal minimum paid vacation days or holidays. Most other developed countries provide at least 20 paid vacation days as a legal minimum. We also have seen in surveys conducted throughout the European Union that when we look at job characteristics, work intensity, job demands has been continuing to increase over the past 15 years in these European Union surveys. However, job control, which can to some extent help us compensate for increasing job demands, since 1995 has been declining. So that's an ominous trend, even in Europe. And this shouldn't come as a surprise to us because we know that precarious work, again, this is from surveys from Europe, means having less control over your work pace, this precarious work. It means working faster. It means making more repetitive movements and thereby increasing the risk of musculoskeletal disorders like carpal tunnel and tendinitis. And it means getting less skills training. Electronic monitoring also means more job stress because when it's introduced in offices, it tends to lead to less worker control. Work is simplified to make it quantifiable. There's an emphasis on quantity and speed over quality, and a climate of fear, deadline pressure, and threat of reprimand tends to be created. Some other interesting data that we've seen from Sweden that has excellent periodic surveys of working conditions shows that since the recession in 1992, the level of hectic plus monotonous work, a measure of job stress, has increased much more for blue-collar workers than for all workers. So some suggestion that working conditions are even getting worse for blue-collar workers compared to white-collar workers. Now, there's very little of this trend data available in developing countries, but in Taiwan, they have had for the last 10 years these periodic national surveys, which also show increasing levels each year of perceived high work stress. Right now, in fact, they're analyzing data from their last two surveys on job demands and control, and we'll have those results to us soon. We know that in developing countries such as Korea or Mexico, or countries considered in transition such as Hungary, work hours are longer than in developed countries. We know that in developing countries over the past generation, many more have seen increases in income inequality, increasing gaps between richer and poorer than countries with stable inequality or those with declining inequality, an increasing trend throughout the world. In developing countries, we've also seen a race to the bottom in working conditions to attract overseas capital in low regulatory export zones, whatever the effects may be on rural dislocation or the environment. Studies show cuts in public sector budgets and social protections in developing countries, downsizing in the formal economy, as well as a growth of the unregulated informal economy, where it tends to be worse health than in the formal economy, and the continuing problem of child labor and forced labor. Some of the best information we have about these issues in developing countries comes from exposés in newspaper articles. Call center workers in India's booming call center industry are facing the same illnesses now that workers in these industries in developed countries have been facing: musculoskeletal disorders, sleep problems, heart disease, depression, work-family conflict. In China, we know that there's continuing high rates of injuries and illnesses, worker abuse, child labor, very long work days, an estimated 100,000 occupational fatalities per year. And lean production techniques have come to China also, with their resulting stresses and increased risk of injury. So what are the health effects of this brave new world that's being created? There's a variety of health outcomes that the speakers will be talking about today. Let me just introduce a few slides on health. We know from some studies in developed countries, for example, that privatization can have health effects. This is a study of British civil servants whose department was privatized, and over a 5-year follow-up period, that group had a 45% higher rate of developing heart disease than a control department, which was not being privatized. Downsizing, similarly, here in this study of Finnish public employees, workers whose occupational groups had high rates of downsizing over a 7.5-year follow-up period had double the risk of dying of heart disease and stroke than workers in occupational groups where there was lower rates of downsizing. When these lean production, Japanese management techniques have been introduced in auto manufacturing, we tend to see increases in musculoskeletal disorders and reports of job stress and fatigue. Another interesting effect we see of inequality in income comes from this study in the United States. When we take all 50 states of the United States and rank them on levels of income inequality, and if we look down at this end of the graph, we see those states that have a bigger gap between richer and poorer, more inequality. And we see that those are the states with the higher heart disease and stroke death rates. The pattern is pretty clear here, the connection between cardiovascular death and inequality. We also see some interesting differences between countries. If we compare heart disease rates, for example, among middle-aged people in the US and England, rates in the United States are much higher than they are in England. In fact, poor people in England have similar heart disease prevalence rates to wealthy people in the United States. Similar interesting effects of inequality if we look at a sample of developing countries. And here, labor market inequality is defined by having a larger informal economy, more child labor, more percent working poor. And those countries with a larger informal economy had lower healthy life expectancy, just within this group of developing countries. Finally, during this period of globalization, up until recently, we had been lowering the proportion of our population that had high blood pressure. We've been lowering the prevalence of hypertension. But now this is reversing in the United States and in other developed countries. We see here in the United States increasing rates now of hypertension and rapidly increasing rates of diabetes. So these are some of the health effects of the world we're living in. And to continue this discussion of work and health, let me turn the floor over to Dr. Schnall.
So let me pick up by talking about cardiovascular disease, which is an area of expertise that I've been working on for a number of years and something I'm very concerned about. We know... Oh,
you went forwards, I think.
Yeah, I skipped a slide, so let's just go back 1 second.
Okay. That's it.
Okay, sorry, thank you very much. So perhaps not a surprise that cardiovascular disease is the #1 worldwide epidemic. and that in the non-industrialized countries of the world, it is the fastest growing pandemic in the world. There have been dramatic increases in cardiovascular morbidity and mortality in the former Soviet Union, the Eastern European countries over the last 20 years. And we see rising prevalence rates of cardiovascular disease in many of the developed nations in the world. By sometime between 2010 and 2020, cardiovascular disease will become the #1 cause of death worldwide, with more than 2 billion people afflicted with hypertension or cardiovascular disease. There's almost 1.7 billion afflicted now with one of the two disorders. China gives us a good sense of what's happening. As a cause of death, CVD was 12.1% of the mortality rate in 1957. Today, or 5 years ago, it was 38%, an enormous increase. And we can see some of the reasons why. The traditional risk factors have been dramatically increasing in China over the last 30 years. Smoking, 61% of men are smoking. 33% of adults in China are overweight. The diabetes prevalence, which is clearly weight-related as one of its causal factors, has dramatically increased over the past years. And hypertension, which was basically not a disease in China, okay, in the 1950s, where somewhere on the order of 5 to 10% of people had hypertension. Today, more than 20% have hypertension, and the number is increasing dramatically day in and day out. In the U.S., cardiovascular disease is responsible for more than 40% of all deaths. And the traditional risk factors, which have been identified over the past 100 years, are all basically recent phenomena. They've come into existence with industrialization. These little boxes here are to indicate to you these. I'm sorry, on my slide they're beautifully highlighted in red. These are basically to tell you what's happening to them at the moment in the industrialized countries. So smoking has been relatively stable over the last decade or two. Cholesterol levels have basically plateaued also in the last 20 years. But obesity, hypertension, and diabetes, all of which are important causes of cardiovascular disease, are dramatically on the rise. And these traditional risk factors are proximate causes. In a large causal model, they would be the ones that would be the closest to the individual. But each has a complex set of determinants, some of which are work organization and psychosocial in nature. Even things like cigarette smoking, okay, are rather recent historical phenomenon. The mass production of cigarettes occurred at the end of the 19th, beginning of the 20th century, and we know exactly that because when we follow lung cancer incidence and prevalence rates, we see that lung cancer becomes a health problem 30 years later, in the 1920s and 1930s. Now, hypertension is a good example for this discussion. It's a disease which for 110 years has remained labeled as essential hypertension, a disease of unknown etiology despite enormous amounts of research. We know it has pervasive effects on the body. It's a major contributor to coronary artery disease and heart attacks. It afflicts at least 80 million Americans and more than 900 million people worldwide. And the traditional risk factors, obesity and salt, genetics, age, alcohol intake, do not explain much of the variance of the etiology of this disorder. It would appear as though hypertension is a disease of modern society. For example, there is no high blood pressure in non-industrial cultures. It's very, very rare to find any substantial elevation of blood pressure in a non-industrial culture. Usually only where there's excessive salt and weight in the population. Hypertension also is socially patterned by all of the relevant variables: class, race, ethnicity, urbanicity, and gender. And so the evidence suggests that there's some unidentified cause or causes which must be ubiquitous in nature if we have 80 million Americans with hypertension. That's so pervasive and widespread that obviously it demands some sort of pervasive set of exposures. The things that come to mind are diet, which has been reasonably ruled out for the most part, lifestyle, which has not been very productive with respect to hypertension, our work, and our communities. Whatever explanation we come up with for hypertension, it must explain things like the absence of it in non-industrial cultures and its social patterning within industrial societies. Here, for example, is some evidence, in case you doubted my word, that it doesn't exist outside of industrial cultures. A massive study by Ingrid Waldron at the University of Pennsylvania, in which she reviewed some 84 different anthropologic studies of both industrial and non-industrial cultures, found that the non-industrial cultures basically have normal low blood pressures throughout their lives, and that the correlation between age and blood pressure is zero outside of industrial cultures. One has to note that cardiovascular disease and hypertension parallel the transformation of our society and of work over the past 150 years. We've gone from an agricultural and relatively autonomous craft-based work society in the 19th century to a machine-based society characterized by assembly lines and mass production. And these jobs have high workload demands and low levels of control, and they have long work hours as their basic characteristics. And now about work and blood pressure, we know some very interesting things. We know that most people spend the majority of their waking hours at work or in their work environment. We know that work activities are increasingly characterized as demanding, constraining, or in other ways highly stressful to people. We know from ambulatory blood pressure monitoring and studies that I've done over the past several decades with Tom Pickering at New York City Hospital at Cornell Medical Center, that when we go to work, our blood pressure goes up 4 or 5 millimeters on average during our workday compared to home, and that our blood pressures on work days in general is higher than on vacation and on off days. We know that performing all sorts of demanding and constraining jobs provokes sharp rises in blood pressure. It appears as though there are specific aspects of work which are implicated as important causes of hypertension. For example, this idea of job strain. So we have identified, colleagues worldwide, these following facts: that blood pressure is higher at work than at home, that things like job strain, long work hours, effort reward imbalance, and threat avoidant vigilant work, I'm going to describe several of these in a moment, and evening and rotating shift work, lack of sleep, which is not on the list, and things like noise, lead, and arsenic are all positively correlated with our blood pressure, and that the more of these we're exposed to, the higher our blood pressure gets. And there's also evidence that there are mediation relationships between these stressors and some of the, quote, traditional risk factors, so that we've seen relationships between job strain and effort reward imbalance, for example, in cigarette smoking, or even with obesity and diabetes. In the Bell stress study, a major European study, job strain is a risk factor for the development of diabetes, which hadn't been looked at until 2 years ago. And also that there may be interactions between one's social class and social status and work stressors contributing to people's development of hypertension. Here's a model of this concept of job strain developed by Dr. Robert Karasik, who's now at the University of Massachusetts at Lowell. And it basically is what we were describing. People who report jobs high in demands and low in control are considered exposed. This is a work stressor, job strain. Or people who put in enormous amounts of effort at work, but who experience inadequate reward defined in terms of their income levels, their ability to have career mobility, or on the flip side of it, the likelihood of job loss and job insecurity, coupled with esteem and respect. People who put in lots of effort at work, but who do not get adequate rewards. There are a large series of studies now showing that this is related to cardiovascular disease as well as some of the mental health outcomes. Here's some slides from my work with Tom Pickering, with Paul Landsbergis, my colleague at New York Hospital, in which we did first a case control study and then 12 years of follow-up relating job strain to people's ambulatory blood pressures. And please, whoops, what did I just do? Oh, got it. Okay. I blanked it. Note that people who report job strain have blood pressure markedly higher than people at work who do not report job strain. And if you follow these same groups of people prospectively 3 years later, and you look at the group of people who have repeated exposure to job strain and compare them to the people who do not have exposure to job strains, no exposure at all, this no group here, you'll see that the chronically exposed have blood pressures 12 millimeters higher than people who are unexposed. And here's a confirmatory story that was published in among Belgian workers in last year. Basically, a similar research design with very similar findings. These are the people exposed to job strain, and that's their blood pressures, 137, unexposed, 127. If you take a number of these studies and look at the relationship between exposure and outcome, note that we can do a calculation called a population attributable risk percent, and for our New York City study, if we take the odds ratio or relative risk, which is almost 3, we can see that this accounts for about 27% of the hypertension among our New York City working population. If we used a repeated exposure variable, which would give a higher relative risk or odds ratio, we would find that the percentage explained would be higher. And similarly, there are a number of studies, all of which show that somewhere between 15 and 35% of cardiovascular disease is related to the single exposure of job strain. The low numbers here are because there's virtually no job strain in the Danish working population. Now, one question comes up, well, what is this interrelationship between social class and work and health? And we want to note that there are both direct effects of class on health. Paul has already presented some of that information. Then there are indirect effects, that is, working conditions and class. What class may contribute to, for example, unhealthy behaviors. It also may increase the likelihood of people being exposed at work to unhealthy jobs. And then finally, there's the possibility that class and work combine in some way to produce an even greater effect among working people. It turns out all of these things are true about class. And here's just a slide that demonstrates the traditional, what we understand of the social class heart, disease gradient. The first group show basically that there's this strong inverse pattern between class and 10-year mortality. This is the pattern for cardiovascular disease and for non-cardiovascular disease. And as to its indirect effect on unhealthy behaviors, work stress. See, we're trapped by it. You can't get away from it. Here is a study of European men and women showing that both men and women are more likely, if they're from a lower socioeconomic status job, to be exposed to something like job strain than people who are from a higher occupational level, managers and professionals. So women in this study, 80% of them reported having job strain. And here's a similar study from Whitehall. Here's a study, the Whitehall study, which is a very well-known study that Michael Marmot directs in England, showing that effort-reward imbalance, the N box here, okay, is more likely to occur in lower social economic groups, just as job strain. So this is a British civil servant population with the same pattern of class inverted relationships to exposures. Here, from the same Whitehall study, is an analysis basically where they adjusted these looking across these different occupational groups. Sorry, but that's my alarm telling me I have to get finished. So if you control for standard risk factors, you see the gradient still exists. And if you control for job control, much of the difference between the lowest occupational status and the middle level disappears. And when you control for all of them, the differences between levels disappear. So there is both an effect of traditional risk factors and the second effect of psychosocial factors. Taken together, if you plug them into the model, the differences between socioeconomic status groups disappears. And similarly for effort reward imbalance, this shows that there's higher risk of reporting effort reward imbalance if you have multiple risk factors. And finally, this interaction effect issue that I just described earlier. Here's a study from Stockholm that shows that among manual workers exposed to job strain compared to non-manual workers, right? This group here, look at this. The folks who have manual jobs and job strain have a dramatically increased risk of cardiovascular disease. So there's something both about the work exposures and the class which come together to either because people are somehow or another exposed to more noxious aspects of work in these groupings, or they're more vulnerable. Okay, we can't quite tease that apart, but that's basically some of the issues that we're addressing. And similarly, an evidence for an interaction for effort reward imbalance with social class. And from our own Cornell study, blue collar working men, okay, compared to white collar working men who are exposed to job strain, look at the difference in their blood pressure. Blue collar men have a 14 millimeter elevation, whereas white collar men exposed to job strain show only a 3.4 millimeter increase in their blood pressure. And with that, I'll turn this over to Marnie Dobson, who will talk about these exposures and their effects on mental health.
Good afternoon. I want to continue this discussion by looking at the effects of work and some of these changing patterns in work as a result of globalization, particularly on mental health outcomes. And we tend to kind of understand intuitively that work stress might be related to, mental fatigue or psychological distress. There's also a lot of evidence that these work stresses that we've been describing, these models, are particularly related to common mental disorders such as depression and another syndrome we call burnout, which is common in the occupational health field in terms of looking at work-related psychological distress problems. I'm also going to present some data on the economic costs of some of these work-related illnesses in terms of the direct costs. Healthcare costs, as we know in this country, are spiraling out of control. But also some of the indirect costs that we may not necessarily think of that impacts business and obviously individuals, sick leave and employee turnover and lost productivity during work as well, which sort of underscores the importance of looking at these effects on illness. Depression is among the leading causes of disability worldwide. By some estimates, it's projected to become the second leading cause of the global burden of disease by 2020. 12-month prevalence rates in the United States are higher than any other country in the world, at least by some estimates. 9.6% of adults in the American population suffer from a depression during a 12-month period. That's almost 20 million Americans. For example, in comparison, the depression prevalence, 12-month depression prevalence in Japan is 2.2%. So you can see it's a lot higher in the U.S. The incidence and costs of mental health disorders also are increasing in many countries. This data from Sweden is self-reported data, but it's a good trend data which is hard to come by, which shows an increase in fatigue, as you can see there, sleep trouble, and also psychological distress over, since the 1980s. We know that fatigue, sleep problems are deeply problematic for many occupations, particularly those that require, alertness and vigilance. We can think of that in terms of professional drivers. Air traffic controllers, Dr. Alan Rosskam's been working on a International Transport Federation study looking at some of these effects of fatigue. But overall, the origins of mental instability are complex. We know that mental disorders have multiple etiologies, and that that these changes resulting from globalization and from work are having an impact or are key contributing factors to depression and mental disorders. we can see that 8% of depression can be attributed globally to environmental factors, in particular occupational stress. And this is in one study conducted by the World Health Organization. As with physical illnesses, Peter and Paul have both discussed, we know that mental illness is distributed unevenly in industrialized societies, which suggests that it has some social etiology. We know women, for example, experience twice as much depression as men. In this, we have many theories for why this might be. We can think about the kind of role overload that many women experience. We know that in the United States, for example, most women with children now also work outside the home, but are still primarily responsible for the unpaid domestic labor in the home. And in this case, this data shows that income, particularly this is data from the United States recently, shows a greater percent of those below the poverty line report higher levels of serious mental illness. This is the same for occupational status as an indicator of social class. In general, lower occupational status has also been associated with higher reported symptoms of depression. And this is a slide from the Whitehall study of British civil servants. You can see in the blue boxes on the right there that they have higher rates for both men and women of depression. This Finnish study shows the increased risk of depression for men who are unemployed and who are contingent workers. And as Paul Landsbergis has pointed out, we know that contingent work is an increasing part of the global economy. In the United States, contingent workers make up a third of the labor force. And in the study, the comparison is to permanent employees over here. Oops, on the right. For women in this study, the risk trends are somewhat different. Women who are in the temporary labor force had a slightly higher risk for depression, even than those unemployed and receiving subsidies. So we know that's an interesting area for future research. So we not only know that there are these more direct effects of work organization, like precarious work and unemployment, that's affecting mental health, and I think that's a long known kind of feature of the economic well-being of a society. But even when employed full-time, we know that even in traditional workplaces, there's a relationship between aspects of the organization of work and health through exposure to chronic work stresses, as we've been seeing. And this Whitehall study, again, of British civil servants, is one of many studies that shows the effect or the influence of job strain, which are high demands and low control, on, in this case, psychiatric disorder using the general health questionnaire. You can see in the boxes on the right-hand column there, left-hand column, a sizable risk for those men and women with job strain. Effort-reward imbalance is also associated with a higher risk of depression. This study of effort-reward imbalance in occupational positions shows that those in a lower occupational rung and who have a high level of effort-reward imbalance have a significantly higher risk of depression, almost 40% higher than those in a similar occupational position with low ERI. So like the data Dr. Schnall was showing earlier, there's an additive exposure in some instance between work stresses such as job strain and effort-reward imbalance with occupational status that suggests that work stress may be a contributing or explanatory factor in social class effects on mental health. This meta-analysis was based on a number of studies that have looked at these work stressors, work stress models, and again show the sizable effect that job strain and effort-reward imbalance have on common mental disorders or risks for common mental disorders. The concept of burnout I wanted to talk about very briefly. It's a series of symptoms that really evolved out of observational studies of the workplace. They're common symptoms. They're often work-related, including fatigue and atypical physical distress. These symptoms are kind of grouped into 3 dimensions commonly used to study burnout in working populations, including exhaustion, depersonalization, and personal accomplishment. Most studies show an association between job strain and burnout, as well as between effort-reward imbalance and burnout. There's a positive relationship. A recent study, interestingly, showed that in a population of Finnish employees, over 3,000, this was a cross-sectional survey, they found that burnout may in part mediate the association between job strain and depression, so suggesting that those people with job strain may experience burnout prior to exhibiting depressive symptoms, although this is a cross-sectional study, so a longitudinal study would have to bear that out. As well, there's a multitude of studies that have looked at the effects of job strain or the experience of job strain on other indicators such as sickness absence. And in this study of nurses in the province of Quebec, we can see that even though the size of the effect is small, in this instance up here it's hard to read, it is statistically significant. So those with exposure to job strain had a higher risk of short-term leave, sick leave, and also medically certified sick leave for mental health problems. We know sick leave obviously represents a significant cost to employers, and I want to present some of this information on costs. The economic costs of illness, whether work-related or not, are borne by business, particularly in the United States, as well as taxpayers. Direct costs include health insurance premiums, workers' compensation costs, which are largely, as we know, borne in the U.S. by employers. The U.S., we know, spends about 17% now, I think, of its GDP on health care annually. In a survey of only 170 of the U.S.'s largest Fortune 1000 companies, these healthcare costs for these 170 companies amounted to an estimated $15 billion a year. We know health insurance premiums as well. Healthcare costs in general have been skyrocketing. In one study, there was a reported increase over the last 5 years of almost 60% in what business was paying in health insurance premiums. As well as indirect costs associated, as well as these direct costs, we have these indirect costs associated with absenteeism, sick leave, as I've said, disability, turnover, and presenteeism, which I won't be able to talk about too much, but it's this concept of reduced work performance when workers come to work sick and obviously for that reason have reduced performance at work. We can think of many reasons why this might be. Many employers in the United States, for example, don't offer sick leave, so if you want to get paid, you have to show up to work. This is having significant costs. By one estimate, the National Institutes of Occupational Safety and Health estimated that in 1999, the cost of absenteeism, tardiness, and employee turnover was estimated at over $200 billion. If you adjust for the rising healthcare costs and inflation, this figure by some estimates is closer to $407.5 billion today. We know that some of the top contributors to these costs include some of the disorders we've been talking about today: hypertension, acute myocardial infarction, and depressive disorders. This study shows that depression costs employers $44 billion a year in lost productivity alone. This doesn't even begin to reflect the many other reasons for lost productivity, including, and also the medical costs or the cost to individuals in terms of quality of life and overall functioning. Just a brief kind of snippet here, but the cost of cardiovascular disease and stroke in the United States, according to a recent report released by the American Heart Association, is estimated at $431.8 billion. So this includes direct costs for healthcare expenditures and indirect costs for productivity loss from death and disability. Now, if we were going to take a conservative estimate of the work-related impact of CVD at about 20%, we can see that there's a sizable cost to work-related cardiovascular disease, of at least over $86 billion. So we know that employers are aware of this. We know that businesses are obviously concerned about the rising healthcare costs and obviously want to do everything they can to reduce these costs because it affects their bottom line. So we do see businesses passing off a higher proportion of health insurance premiums to employees. We're attempting to reduce workers' compensation costs. We see a greater restriction of the number of conditions that are labeled work-related, and obviously a resistance to labeling more conditions as work-related. We see an increase or a rise in worksite wellness programs that really are aimed at the individual and reducing individual health behaviors that might be contributing to this. In an interesting study of with interviewing key business leaders and stakeholders, business consultants, for example, a colleague of ours, Dr. Deborah Gordon, found that business has really yet to focus on the deleterious effects of the organization of the workplace as a way to deter productivity losses and health problems in their employees. So, you know, we can't rely on business really to take a stand on maybe redefining the work environment to try and reduce these costs. And Alan Rosskam is going to talk about some of the other ways that that we really need to start looking at in terms of change at the workplace level, change nationally and even internationally. Thank you.
Thanks, Marnie. Will this work from here?
Sure.
Okay. Yeah. So you've heard a very heavy body of empirical evidence that is a rather dismal tale, a reality check of what's happening that is very, very seldom talked about. You'll probably never see in the press outside of today's seminar, but hopefully after today you will. But before we all get up and want to move to Denmark, I think we can now listen to a more optimistic and positive note. I think I'm going to ask you to do this, if you don't mind, on how we can actually go about making change to reverse the trends that have been presented to you and what needs to be done based on what's working elsewhere in the world. We are not an island. We are part of a global village, apparently. So if we look first at job characteristics as a way to make change to address low job control, low level of rewards, high level of demands, and social isolation, we can expect that more action research, more labor management committees, and job redesign would be the key areas that we need to be focusing more on. Next slide, please. Participatory action research is one method of research that is unfortunately far too little used by researchers in turning research into policy-level practice to make local, state, national, and international level policy changes for all kinds of improvements. I could go on for a week of giving you wonderful examples, but I'm just going to give you two today. In a study of hotel room cleaners in San Francisco and Las Vegas, participatory action research methodology was used and amongst mostly female, immigrant, and low-wage workers. It was a study conducted by researchers and the union exclusively together, and the results of the study led to a change in both the 1999 and the 2007 contract negotiations, the contracts that were achieved by labor management, reducing daily room quotas and addressing wages and employment contracts for other groups of workers in the hotel industry. Next slide, please. A study that I conducted in Switzerland and Canada on airport check-in workers, also a largely predominantly female occupation, although in Bangladesh it's male only. Some of the key results, I'm a victim of my own success. I now, every time I travel, have to stick my baggage on a bathroom scale to make sure it never goes over 21 kilos, because since this study that has been adopted as a universal policy. So now we jump from what was local level to international level, and you can see how research can be truly translated into international level policy change. The international press coverage that came out of this study raised a huge amount of awareness. A seminar that we held at the International Labor Office in Geneva, which is a UN agency, in 2003 catalyzed both union and management action in Switzerland on to improve not only working conditions but also wages and employment contracts. 15 labor inspectors from the canton, the state of Geneva, came to the seminar, and the very next week, the one that was responsible for the airport in Geneva, Switzerland, convened management, the union president, and started working out new negotiations. The International Transport Workers Federation, which is the global union federation that represents civil aviation workers around the world, including ground staff, including check-in workers, used the results of the study for a campaign to re-professionalize the work of check-in workers. And the fact that the ITF sent this report of the study's findings that included recommendations for both management, and unions to its collective bargaining agents in 200 countries around the world meant that for the very first time, those collective bargaining agents in 200 countries had empirical evidence that they could use to bargain with management for better working conditions, wages, employment contracts, better work organization, and opportunities for skills development. Next slide, please. But there are other approaches that can be used in addition to participatory action research. For example, Kaiser Permanente, which I think is the largest healthcare provider, insurance company in the United States, has, instead of a collective bargaining system set up with a union, they have what's called their labor management partnership. And they have achieved tremendous agreements that are improvements that are agreed upon by management and employees together. The one difference between this kind of a partnership to keep in mind compared to that of a trade union management agreement based on collective bargaining is that in a labor management partnership setup, employees don't have that last final bargaining chip, which is to strike. So it's all discussion based, but there's no final bargaining chip. They're trade-offs. Anyway, it works very well. The Maintenance Cooperation Trust Fund, which is a Taft-Hartley fund under the Taft-Hartley Act, works in California through state legislative arms to bring enforcement to misbehaving employers of janitorial workers who are very often exploited and underpaid or not paid. And the MCTF has been extremely successful in using the state legislative arms in California to get penalties imposed on misbehaving employers to level the playing field for correctly behaving employers and to get back wages paid to janitorial workers who were denied their wages. Next slide, please. The scientific evidence, you can put it all up. The scientific evidence supports the fact that we now know that work organization leads to increased employee job control, less absenteeism, increased performance on the job, and a Finnish study that was conducted revealed that a collaborative approach in interventions have led to improved coworker relations, better employment security, and stronger social support, which is an important buffer against job strain. Next slide, please. Now, in terms of organizational context, we can look at new systems of work organization, collective bargaining, and principles based on workplace democracy. Next slide, please. For example, as one system of work organization, the socio-technical systems approach has mainly involved job redesign and the use of self-directed worker teams. That's little used in the United States. In those teams, there's a great deal of autonomy and longer work cycle times for tasks. You've maybe heard of these experiments in auto manufacturing at Volvo and Saab auto manufacturing plants. Next slide, please. A couple points about collective bargaining. While many positive examples around the world exist to show improved protections through collective bargaining, it's noteworthy that the 30-day heart attack death rate in California hospitals with a registered nurses union was 6.8% lower than the death rate in non-union hospitals. This is quite significant. The 2004 study that had these findings adjusted for many hospital variables such as doctor ratios, hospital size, cardiac treatment services, urban-rural divide, and so on. Next slide, please. And to provide one last example of how collective bargaining has achieved measurable improvements in worker health and performance, the Communication Workers Union of America, together with AT&T, worked together to eliminate the measurement of individuals at work and secret monitoring of employees, and instead they introduced supervision by peers and discussing calls with employees, all of which led to fewer customer complaints and grievances and reduction of absenteeism. Next slide, please. And finally, the top level of the chart, and perhaps the most difficult, is the economic and political context, which relies on legislation, regulation, and social movements. And this is the final piece of the tale. These have to be implemented all together. Next slide, please. At the end of President Clinton's second term, he approved a national ergonomic standard. One of the first things enacted in the first term of the present administration was to repeal and eliminate that national legislation, which was heavily lobbied against by industry in the U.S. Besides what's shown here on this slide, there are numerous other issues in the U.S. and abroad that need federal and or state level legislation. As Paul mentioned, it's striking that the United States is the only industrialized country in the world that lacks federal legislation guaranteeing working people paid vacation time. In our country, instead, this decision is left to employers, which many offer as a benefit rather than a guaranteed right of all citizens as it's viewed in West European countries. This is a very different shift in ideology. But this is conflated with the longer work hours that Americans work compared to other comparable countries. And we have demonstrated to you empirically today that these together are a guaranteed recipe for ill health and high health care costs. Next slide, please. In 2007, the Kennedy-DeLauro proposed legislation that's now under consideration would be a major step forward in protecting workers in small and medium-sized enterprises. You can read the details up there. And something I find of particular personal interest is that Senator Clinton has endorsed a $5,000 baby bond, which would be a small one-time universal income grant. For the time being, she's endorsed it, but no formal proposal for a baby bond has yet materialized. The idea is to give every newborn child in America a bond that would mature when the child comes to age 18. The Associated Press quoted Senator Clinton saying that she liked the idea of giving every baby born in America a $5,000 account that will grow over time so that when the young person turns 18, if they've finished high school, they can access the money to go to college, maybe put a first home down payment down, or use it in any way they choose. Next slide, please. Legislation in Europe and regulations in Europe are far more protective and progressive than what we have in the United States, and they really lead the way around the world. History shows that in our American democracy, protective policies tend to get implemented through the pressure of collective voice groups, holding people to our constitutional rights of by the people, for the people. I think that these rights need to be called upon on a regular basis by Americans to ensure that the protections that are meant to be guaranteed to us actually reach us. Next slide, please. The 1977 Swedish Work Environment Act is a very important example for us. Similar regulations exist now today in various European countries, but in Scandinavia, the pressure came starting in the 1970s from the labor movement due to concerns by high levels of absenteeism, stressful work, and research showing the mental health effects of stressful work. This is an excellent example of results-based research that turns research into practice and is a shift from the past directions, and which is, interestingly enough, now in the U.S., the now stated focus of the U.S. National Institute for Occupational Safety and Health. Next slide, please. In England, from 10 years, from 97 to 07, the Labour government has made tremendous strides to strengthen the social safety net, to reverse the increase from the 1980s in income inequality and poverty. They've cut the poverty rate in half since 97. Their minimum wage in England now is twice that of ours in the U.S., introduction of tax credits and so on. But in the global economy, we also need to try and influence trade regulations and other kinds of regulations. Next slide. This slide is important. From a 2006 study covering 1969 to 1996, and it was published in The Lancet, it shows the connection between health and progressive political activity in OECD countries, including the United States. What this table demonstrates is that progressive governments and policies do make a difference in health, including reducing infant mortality and increasing life expectancy. Measures of Social Democratic Party's cumulative years in government, public health expenditure, and health care coverage are not actually bad proxies for the concept of a just or a good society. Next slide. So while we continue to learn over the years, our teaching of occupational health and our laws don't seem to reflect what we've learned. I put to you here a notion of a new conceptualization of occupational health, one that moves away from medical and technocratic approaches, and one which would be based on citizenship rights approaches and principles of universalism. I think that the absence of any of these points should be considered totally unacceptable in 2008. Next slide, please, Paul. And here I present to you a groundbreaking and forward-looking means of measuring how well governments around the world are protecting the health of their working populations. No such index has ever been developed before, and no such measures exist of governments' performance on protecting the health of their populations. This is the first ever such model to use indicators to measure the performance of governments on protecting their working populations. The indicators that are shown on this slide are the basis for social indicators and include the ratification of relevant international labor conventions, or else the existence of national laws, which are given extra weight statistically if they are at least as stringent as the international labor laws. So how can we use this index? Next slide. We can use this kind of measurement to rank countries by regions, to rank states in our country, to cluster countries, to prioritize, and to know where our money and our human resources will best make the biggest impact, rather than just throwing money out there without an empirical or statistically based indicator of where we need to put our resources most. So I'm sure you're dying of wondering now, out of 95 countries around the world, where did the U.S. rank? Next slide. Not too well. Out of 95 countries, the U.S. ranked 29th, just between cushion Slovakia and Croatia. Now, before you get too upset and excited, let me explain that the fact that the United States does not ratify international labor standards and that our national laws are not as protective as those international treaties, we lost a lot of statistical weight in the building of that index. But there are other reasons too, like the absence of paid sick leave and guaranteed vacation time. So we can do much better. I guess I will skip the next few slides and go straight to the end. Skip, please, Paul, to 117. I come to the last three slides now, quickly. ILO household surveys among 48,000 working people in developing and transitional economies showed widespread support for the provision of social and economic security for all forms of work. There was strong voiced support for a floor principle. A floor meaning, next slide, a floor through which no person should be able to fall. This differs from the concept of the social safety net. Multiple pillars of support and social provision are needed, with the state governing and providing the pillar and overseeing the entire structure. I would like to highlight here today the distinction between government and governance, because we and countries around the world since the 80s have been living in an era of a shrinking and lack of governance, which has been conflated with the concept of shrinking government. We need governance to ensure national stability in any country around the world. Second to last, and this is my last slide. Primary prevention is very much needed around the world, which would involve, for example, combining job stressor reduction with ergonomics, which would be a way of dealing with causes rather than symptoms. And primary prevention should be combined with secondary prevention, which would focus on things like health promotion and stress management. Again, this focuses on the individual. And tertiary prevention is treatment-based, which should be ultimately the last recourse. Through sound policies, such as those in the European social model, we can reduce the use of tertiary care, reduce healthcare costs, improve productivity, and achieve healthier populations. I'll now turn to Peter for some final concluding remarks. Thank you.
Thank you, Ellen. Wow. That was a lot. And I could certainly understand if you're ready for us to get finished, so you can digest this. Let me just a few final summary kind of points about all of this. We've indicated our concern about the impact of increasing social inequality. We've tried to show you that there is a large body of research which is widely accepted outside the United States relating both social inequality and work to health outcomes. And we've tried to give you a handle on why we believe that these global epidemics are socially based, that they're not natural diseases, and certainly not the results of aging. All of the chronic illnesses that we live with are social creations. They are the products of the way we've opted to live our lives, and they come with modern civilization. And the good news is, because they're socially created, they're also preventable. And we can change the conditions under which we live to make these diseases go away, if not immediately, eventually with time. We've identified some of these aspects related to work organization. There are other ways of organizing work so that people are not, being burdened by cardiovascular disease or work-related mental health conditions or musculoskeletal disorders. Automobile workers, 90% of them report working in pain at least one day in the previous month in a study which we've done with automobile workers. So work is important in all of this. It creates chronic conditions in people, biological arousal, psychological arousal, which leads to exhaustion, and physiological arousal in terms of blood pressure. This is different than simply reporting that one feels stressed. Most working people who are exposed to work organizational factors and psychosocial stressors are not reporting stress as their main phenomenon. Even with this widespread acknowledgement of how much stress there is in the workplace, studies that look at self-reported stress and cardiovascular disease have drawn nothing for 100 years. Okay? Most of us who work in a work environment take the work environment as given, and we don't walk around complaining about it. Okay? We live with it, but that doesn't mean that we're not being exposed to a whole series of characteristics of that work environment that require us to turn on and be more aroused, to be more alert, to be more intent, to be better at these things. So this is something that needs to be kept in mind in looking at all of this. And finally, I think this has to be clear from everybody's presentations. Of course, there is the European model of how they have tried to balance work and capital's interests, and I could show you a slide about all the characteristics of it. But I want to say just one more word about what healthy work constitutes and what we need. It's like that old World Health Organization definition of health. It's more than just the absence of disease. When we talk about a healthy work environment, we don't mean simply that all the really noxious things are taken away from the work environment. It means that people need to have a sense that their jobs are important, that they're using their abilities and their skills on the job, and that the job makes reasonable and fair demands on them, and that they are treated with respect and not as objects, not things to be used and thrown away. Thank you.
Thank you, Pat. It's been a terrific overview, and we really have heard causes, consequences, and nicely enough, some cures. Now, we're going to turn to Josh Bivens, who will add a fourth C in terms of commentary.
Can I get the clicker?
Oh, yeah, sorry.
Excellent. There we go. Thank you. Okay, well, I want to thank the Wilson Center for inviting me. Hopefully, I'll be able to add some value to this discussion. I have a feeling some of it may be better in the Q&A, so I may go through these slides relatively quickly. If one grabs your attention, either feel free to shout out, or if you're too shy, make me come back to it in the Q&A or something like that. I would just note, I think the presenters make a very compelling case that inequality and class differences and social exclusion lead to poor health outcomes. And I'm going to admit an interest in this. It's easy for me to believe that. I work for an institution that's kind of dedicated to the proposition that we need to do much more as a society to reduce social exclusion and inequality, so I'm probably an easy audience for them, but I've found it compelling regardless. As mostly a dilettante in this, but completely a dilettante in this specific subject, my endorsement of the results probably don't mean much, but I'm going to suggest to you that accepting their results contributes to our understanding of what should be a puzzle. And the puzzle is this, if I can make it go right. People generally know this story. In this graph, there's a million different ways you can do it, but this is a graph that shows one measure of health outcomes, life expectancy at birth, and health spending per capita for the OECD, which is essentially the rich industrial countries of the world, plus some members like Mexico and Turkey who are not necessarily described as rich, but are essentially, you're talking about the industrial peers of the United States. Life expectancy at birth may not be the best summary measure of health outcomes. It turns out that this general relationship holds pretty much no matter what you put in there, and so we use life expectancy because people kind of understand it. And essentially what you see there is the U.S. is just a huge outlier on this graph. You have to look all the way to your right, or left on that one, I guess. But essentially the U.S. is out there at over $5,000 per year in 2003 in terms of per capita spending. The next closest group of countries is Switzerland, Norway, Luxembourg. They're more than $1,500 behind. And the U.S., as you can tell, does not stand out as particularly great on the life expectancy scale. And you take my word for it, or I can actually send you the sites if you're in any way interested. Come to me. This is a pretty robust relationship. It is hard to find a health outcome measure on which the U.S. looks great compared to its industrial peers. And we spend a lot more money. This should be a puzzle. And so I'm going to argue that the presentation we heard today makes us want to look at how does the U.S. stack up relative to its industrial peers in terms of measures of inequality, poverty, social exclusion. If it turns out that we look quite a bit worse than them, and I'm going to make the case that we do indeed look quite a bit worse than them on these fronts, maybe that goes some way to explaining why we can't get better health outcomes even though we seem willing to spend lots and lots of money. The next couple slides kind of reinforce this point. I'm going to skip through them for now so we can sort of maximize Q&A. They're just measures of how much we spend and how little we get from healthcare. If you want to linger on one, please do it in the Q&A, and I'll talk about it. That's spending as a percentage of GDP, infant mortality rates. This one is relatively interesting. It sort of interrupts the flow of the argument for a second, but that's fine. One objection you often get when you compare sort of the U.S. healthcare system to its industrial peers is the idea that, one, government has a much bigger role in the provision of healthcare in other countries. That's not a problem in my book. And then people say, oh, but that leads to healthcare rationing, the idea that people will not get needed healthcare for some reason or another. Well, we ration in the U.S. If you look at this slide, this is the percent going without needed healthcare due to costs for the total population and for low-income adults. If you just look at the total population, that's the light-colored bar in this graph. You see the U.S. leads the field in these five groups, these five other economies. Canada and UK are sort of the poster countries for having socialized medicine and single-payer, I think in reverse order. So essentially, the U.S. has a lot more people going without needed care due to costs. I call that rationing. I think any reasonable person would. And for low-income people in the U.S., the gap between rationing between the U.S. and industrial peers is huge. So, to me, the idea that we're not rationing, I mean, that's the nature of healthcare. Healthcare is going to be rationed by somebody. We're doing it right now in the U.S. on a very decentralized basis, and I would argue to at least as big an extent as other countries. The only slide in my presentation I have that is purely U.S.-based is this one right here, but I find it interesting enough to put it up there. And it's, again, really suggestive evidence about the link between social class and health outcomes. And what we have here, it's from a working paper by the Social Security Administration, and it's expected longevity at age 60 for males. And it turns out you look at males because they have a much more consistent earnings history and Social Security data than women do. And you compare 1972 and 2001, and the light bar is workers in the bottom half of the earnings distribution, and the dark bar is workers in the top half, and you look at life expected longevity at age 60. And essentially, for people in the bottom half of the earnings distribution, longevity increases by 1.9 years in this 28-year period. For people in the top half, it increases by 6.5 years. And that's even starting from a higher base. And so I showed the original graph that so the U.S. doesn't look great relative to its industrial peers in terms of life expectancy. If you dig within the United States, it doesn't look very good at all if you happen to be stuck in the bottom half of the earnings distribution. So that's my only U.S.-centric slide, but I think it is a really good suggestive piece about the link between inequality and healthcare outcomes. So now what I'm going to do is I presented the puzzle. We spend a lot on healthcare in the U.S. We don't seem to get great outcomes. Maybe we now turn to issues of inequality, poverty, social exclusion to see if the U.S. is any kind of outlier on these. And I'm going to argue that they are. And so I may skip over some of these, but I'll at least linger on the highlight slides and the big measures, inequality, poverty, and measures of other measures of social exclusion. This first one, sorry, it's kind of small. And so this is relative income comparisons in the OECD. And so this is the U.S. industrial peers. And the bars that go in either direction, this is the percent of median income received by households in the 10th income percentile. That's going this way on this graph, versus the percent of median income received by high-income households. And so essentially you see, take the U.S., that's at the bottom there. A household in the 10th income percentile in the United States, they make only 39% what the median household does in the United States. And so, in 2007, 2006, median household income was between $45,000 and $50,000 in the United States. That means households at the 10th percentile were only getting 40% that, so they were getting around $20,000. And it turns out that gap between the 10th percentile and the median is greater in the United States than for any other country. So this is a relative measure of inequality, pegging it to each country's median household income. And then you see our rich households at the 90th percentile, they make more than twice what the median does. Only the UK beats us on that measure. So this is a measure of relative inequality in the OECD. Probably a more famous measure that people may have seen is, let me show you this one. This is, I don't know if it's famous, this graph, but the story is famous. This is the share of total national income claimed by the top 0.1% of families in the United States over time compared to France and the UK. And essentially, the real story, there's lots of interesting stuff going on, but if we just focus on, say, the last 25 years, the U.S. is that blue line with the squares. And if you look from, say, 1979 till 2002, you see the top 0.1% of families in the United States increase their take from about 2% of total national income. This is not really national. This is income reported to the IRS. So it's not quite total national income, but it's a good percentage of it. They increase their take from 2% of that to almost 8%. And to put some numbers on this, we're talking about essentially the 150,000 richest families in the United States who have average incomes of $4 million per year. This is who this group is. And this is how much they've increased their take of total taxable income. Going from 2 to 8% of total taxable income, you're talking roughly $500 to $600 billion being shifted to that group over that past 25 years. That's Pentagon spending, essentially. That is how much income, that is essentially what the Pentagon takes in a given year.
Doesn't that coincide with the introduction of the taxpayer identification number that the banks made the rich people report? How much they actually have? 1984, 85?
The big jump is the big jump in 1986 that you're seeing there. There's definitely some tax shifting going on there. I would say if you just want to then say look at the 86 to 2002, you're still talking about a 3% of. But you're right. There are definitional issues in this for sure. So that's the most,
That was what was due to.
I don't know, impressive measure of inequality. I don't know what the word is exactly. This measure is, what is that one? Is that composition of high? Yes. So this is a measure of, instead of relative inequality, it's sort of measuring what rich and poor households in other OECD countries make relative to the U.S. median. So this is more of an absolute measure. So it's one thing to say that relative to the median household in, say, Australia, the poor Australian household makes a lot of money. doesn't look that unequal, but we may want to know in some sort of absolute measure, how do households stack up across countries? Turns out that's really hard to do. One of the few studies that has done it really well is by Tim Smeating, has a number of papers at the Luxembourg Income Study Project. They're excellent. I would encourage people to look at them. But essentially, this shows what share of the U.S. household median income is made by low and high income households in other countries. So take, for example, the numbers in the U.S. are obviously identical to the other slide, because all this is relative to the U.S. Take, for example, that country that's missing right above the United States. That's actually Canada. That somehow managed to drop off the slide when I popped it up bigger. So essentially, the household in the 10th percentile in Canada, sort of the poorest 10% of Canadian households, they make on average about 45% of what the U.S. median does. So even in absolute terms, sort of purchasing power, the 10th percentile household in Canada is better than in the United States. Now, that's not true across the board. We're a pretty rich country. So if you measure anything by percentage of our median income, other people can start looking okay. There's a number of countries that manage to beat our 39 number, but then there's still a number of countries that even in absolute terms, are quite a bit poorer than the United States at the 10th percentile. But this kind of answers the question, would you rather be in absolute purchasing power terms, forget about social class or reference groups or anything like that, would you rather be at the 10th percentile in Canada or the United States? Well, in this year, given this on pure purchasing power, Canada wins. That's not the case across the board, but this is trying to peg it to a more absolute measure, not just a relative measure of inequality. Just going to show, I think, one slide on child poverty rates, and this is, I think, the most interesting one. This is child poverty rates before and after taxes and transfers, and the light blue line is before tax and transfers. The dark line is after for each of these countries. And so essentially, if you look at the United States near the bottom there, before you take into account taxes and transfers I'm talking here, temporary aid to needy families, all the things that we sort of lump under welfare payments along with other things. If you look before those taxes and transfers, the child poverty rate in the United States would be about 27%. Given that we do have redistributive policies in the United States, we managed to knock that down to about 22%. You see the average of these countries, excluding the U.S., the pre-tax and transfer poverty rate, it's pretty high. Even in other OECD countries, I would say what really distinguishes us relative to many of our industrial peers is they seem to do a better job combating it with taxes and transfers. I mean, there's almost an 11% gap between the pre and post, and that's something that we haven't been very successful with doing. And it turns out that transfers work. This is a measure of child poverty after taxes and transfers versus how much social expenditures as a percentage of GDP. Makes a lot of sense. If you give money to people who need income, it tends to lift them out of poverty. And that's essentially this trend line. The U.S., again, is an outlier. We spend very little as a percentage of GDP on social expenditures. I'm just going to do one slide on this one because one issue that is often brought up, and that's the one. When you point out sort of where the U.S. stands in terms of inequality among its industrial peers, people often say, well, the flip side of inequality is mobility. People are moving up and down the income ladder a lot, and so maybe that's what's going on. This is economic mobility in a study that was done in the 80s and 90s. This is essentially looking at families who earn less than 50% of the median income in a given year. What is their probability of earning more than 50% of the median income within a 3-year period? And so essentially you've got low-income families able to exit low-income status over a given 3-year period. This is a pretty short-run mobility study. It turns out that longer-run studies, I've got some slides on them. They show essentially the same story, except the UK looks a little bit worse than us on the long-run mobility studies. But the US is near the bottom of the barrel, and in this case, it comes out absolute last. The lowest percentage of low-income families who are able to exit low-income status within a 3-year period is the United States at 29.5. I'm going to skip over for now a couple of the other mobility studies. So I noted before that one way that the U.S. seems to be an outlier is that it turns out we're richer than any other country in the OECD in terms of pure per capita income. We seem to do very little in the way of transfers. We have more inequality. It may be useful to step back and say, well, why exactly are we richer then? That's a good question in and of itself. Is there something about sort of a more free market, less government transfer economy that leads to huge productivity gains that sort of is the payoff to tolerating some of the social exclusion? And so the way to read this slide is just look across from the United States. Just read across the row. You see our per capita income relative to the OECD is 30%. It's 30% higher than the OECD average. And then the next three columns, productivity, hours worked per person, labor utilization, they give you an idea of how much of that 30% gap, that is our advantage over the rest of the OECD in per capita income, can be attributed to being more efficient, that's productivity, just working longer hours worked per person, and labor utilization is it's essentially a business cycle control. It is what is our unemployment rate relative to other countries at a given point in time. And turns out we are more productive than the OECD average, but we're far from an outlier there. I mean, if you look at Germany, France, Ireland, which is a real strange one, I have to say, and Norway, those are all about in our league in terms of productivity advantage relative to the OECD. Where we really stand out is hours worked per person. Really, you're only looking at Australia, who even comes close to us in terms of how much above the OECD average we go in hours worked per person. Labor utilization, we seem to be roughly in the pack. We have slightly lower unemployment rates than lots of other countries in the OECD, but we are not, contrary to what a lot of people think, a huge outlier in that one too. There are a lot of OECD countries that have low unemployment. There are some big prominent ones, France and Germany, that do not, but France and Germany are not the totality of Europe. So essentially the one big reason why we have a per capita income advantage over the rest of the OECD, and we do have a pretty substantial one, I'm going to argue is not because something about not doing transfers, ignoring inequality, ignoring social exclusion has been a royal road to growth. We simply work a lot more hours than most other countries. And that was actually a slide in the other presentation. And so I have that slide, and I will go over it since you've seen it. And you've already seen this one, too. This is paid vacation and holidays. That graph is kind of funny because people think that last bar is the U.S., and it's not. The U.S. just doesn't have a bar. Is it at 0? And now just I'm going to end with two things. Real serious measures of social exclusion that often aren't talked about enough. First is the prison population rate. The U.S. is just off the charts on this one. I think there was a report recently, I can't remember who did it, but I think we have passed 1 out of every 100 adults in the United States are now incarcerated. I would argue that's serious social exclusion, and it's got to be on the minds of people who worry about this. And then the last slide that, God, you will not be able to read. Sorry, there's too much stuff. But let me just try to point you to what I'm looking at here. I'm actually only wanting you to look at one column. It's this last block over on the edge away from the countries. It's titled Not in Education and Not Employed. And that, to me, is a pretty good category for some social dysfunction going on. And especially if you look at the age group 20 to 24, which is the middle column under that block. Essentially, I would argue if you have people aged 20 to 24 who don't have a job and are not in college, that's a problem. And that's going to be a pretty good measure of social dysfunction. And if you look at that number, the U.S. doesn't look great. We're at the bottom. 15.6% of people between 20 and 24 in the United States don't have a job and are not in school. The U.K. looks to be almost as bad as us. If you go down the chart, there are definitely people who look worse than us. They tend not to be countries you would call our industrial peers. I remember 2 years ago, I'm just about done. 2 years ago, there was the big demonstrations in France. The students were protesting against a proposed change in labor law that would have allowed people under 26 to be hired on a purely temporary basis and fired at will. And lots of commentators tried to make a lot of hay over high youth unemployment in France. And there is high youth unemployment in France, and it's definitely a problem. But it turns out that a much higher share of people 20 to 24 in France are in college than the United States. And if you look at what I think is this most relevant measure of youth dysfunction, of social dysfunction, youth not in college, not with a job, youth, 20 to 24, I don't know if that's right, young adults. Essentially, France looks actually a tiny bit better than the U.S. on this. About 14.4% of people in France, age 20 to 24, don't have a job and aren't in school. We're compared to 15.6 in the U.S. So I will end with just this one. These are tables from my paper, so I'm not going to have you trust those, but ask me about it sometime. This is how much has globalization contributed to this rise in inequality. And this is a chart that tries to attribute a change in the Gini coefficient for advanced economies in the world to globalization. And it turns out, if you look at the advanced economies, it looks like globalization is making a substantial contribution. And if you want to know the source on this, this would be the IMF. This is them. They actually have a larger contribution than I find in my paper that I have tables on. But I will go straight to a source that people probably won't think is too biased in favor of thinking globalization is a terrible thing. And the last thing I will just say, shameless plug alert, we've got a whole policy project, the Agenda for Shared Prosperity, at this website that is our sort of menu of solutions about what to do about bringing the U.S. sort of closer to its global peers in terms of inequality, poverty, and social exclusion. Anyone who's interested, I would urge you to check it out. And that's it. I welcome your questions.
Thank you, Josh, very much. That was I think a lot of us would like to read that paper, too.
Yeah.
And I do want to remind everyone that the causes, consequences, and cures are going to appear as that unhealthy work, rather, later in the year. You see it up here. And I believe that's going to come out in 2008, but a little bit later this year. Well, why don't we turn to questions and answers? Gentleman over there, and then we'll come to Stillman here.
Two brief questions. The first is, have any comparable veterinarian studies been done of the health of animals in a herd or pack that are at a lower status level in relation to their peers? And in policy terms, the unique role of the United States as the military superpower, along with, in terms of the health consequences of having people serving in combat in the military and on their families and children, how that affects the American health picture.
I'll take the second part.
Well, the first part about the animal studies, there's been plenty of them. Why zebras don't get ulcers. I mean, there's plenty of studies about our primate, neighbors in terms of hierarchy and its effect on stress levels, and the kinds of things that will produce stress in animals. You can produce enormous illnesses simply by taking a female baboon from one group and transferring it to another. That means the normal social hierarchical relationships for that animal has to be completely reassessed. And while that's going on, they're under enormous stress, and they'll develop all sorts of illnesses. So I think that there's this body of literature out there that's sort of consistent with our notion that human beings who develop hypertension are experiencing chronic biological arousal as a result of social conditions. And I think the animal literature results are consistent with that.
As for your second question, that's a great question. I was actually really hoping somebody would bring that up. There are studies done on soldiers in the military, in the field, that show extremely high rates of chronic stress and severe health consequences when they come back. And without any question, that contributes very much to the health care costs and the burden in the American society. Yes.
Yeah, Chia Chen, freelance correspondent. I have a comment. And
you can just go. We're really short on time. If we go to the questions,
okay.
Maybe you could do the comment afterwards.
Okay, I don't have question. Yeah, I think just when we talk about economy, globalization, and this so-called two forces, privatization and liberalization, really is sure. It's just the last speaker said have economy advance, but then there's some human cost and social cost, like the occupation disease and ergonomic problem you have mentioned here. So I think then we probably should have a third force, and I think it's I call maybe somewhat right to know. First is the people in the host country need to know what's the safety and health in a particular company. And also second is this, should get this health effect and environment degradation known. And I think here we have a presenter is from two good institutions, is UC Irvine and Mount Sinai School of Medicine. I think you people probably should have in the front to spread those information. And also, I think one more long term is you probably should help the local host country set up the School of Public Health. Thank you.
Do you all have any comments on?
Our best.
I think it's a great comment.
Yeah. We're doing our best.
What about the existing set of great companies to work for? Do they capture some of what you're after, or are they looking simply at hours or just one element of what you're talking about?
You know, it's hard to really get a good handle on, you know, on what companies are doing in terms of occupational health and safety. As I mentioned briefly, a colleague of ours, Deborah Gordon, who's actually in the audience, has done some qualitative work actually talking to leaders in business communities about their occupational health and safety programs. And, you know, a lot of it is focused on the individual level, looking at, you know, trying to intervene in terms of the proximate causes, you know, the risk factors like smoking and diet and encouraging exercise. So more focused on individual level factors than, you know, really focusing on maybe some of these work organization stressors that we're seeing, like even long work hours, for example. So I'm not sure if there's data beyond that.
I mean, you may get the feeling from listening to us that we're about ready to throw the baby out with the bathwater. I mean, there are many good companies in America to work for. I mean, Fortune magazine has a Fortune 100 list every year. And many of them are characterized by the fact that they value, there's a culture, a culture, you know, of valuing their employees, basically, and valuing their health, basically. I mean, even if you say it's just a question of capital preservation, you know, that they have all these well-trained and highly qualified people, but they do want to keep them happy, and they do want to keep them involved. I mean, companies like, you know, Hewlett-Packard, you know, invented all this, leave time arrangements. You know, Alcoa has a huge research program on looking at the occupational health consequences. I mean, the list of companies is extremely long, which have very progressive attitudes about their work environments and who are making changes. But I do think it's fair to say, and I think Paul made this point, that oftentimes when they focus in on trying to reduce the burden of health and illness, they focus in on the individual level. Even when they are progressive companies, they're thinking in terms of health promotion. They're not thinking in terms of health protection. How can they reorganize the work environment so people aren't getting sick? And that's one of the messages, you know, we're trying to get across with this presentation, that there are other approaches to the work environment that will benefit companies both in terms of better health and lower costs in terms of productivity losses and disability and health outcomes that are an enormous burden on these companies. I mean, the costs are well over $1 trillion a year for all of these work-related injuries and health outcomes. You know, proving, you know, that connection is very difficult, you know, because we don't have good data in the United States to look at, okay? But we think, you know, there have been a number of papers which have suggested that the consequences are enormous. But yes, plenty of companies that are concerned about this issue, and we work with many of them, as well as with unions which are concerned about their workforce as well.
Could I add a comment to that? A great book to read is called Maverick by Ricardo Semler. If you haven't read it, it's a fabulous Sunday afternoon read. It'll keep you smiling for a month. He's the president of SEMCO in Brazil, which has been going on for decades, and even through the economic slump in the 80s, this company continued to reinvent itself again and again and again and make profit after profit after profit. How? By reverse pyramid, where workers are at the top and make all decisions. No decisions are made. They have so many innovative ideas that the list of companies from Europe and the U.S. every year that want to go visit them to learn how they do it is longer than what they can accommodate. So Maverick by Ricardo Semler is a great book. And following on the last point Peter made, it's also very important to note, and I don't think that any of us mentioned this, that one reason it's very difficult to have good data in the U.S. is because, unbelievably, the labor databases, the labor databases that are collected by the Department of Labor in the United States and health databases collected by the Department of Health and Human Services in the U.S. are never merged. They are never connected. Political agenda, stupidity, whatever you want to think of it, it is unbelievable.
The lady there has it. Oh, lady there, and then we'll go. Well, you've got Mike, and we'll go to the lady right down the way. I beg your pardon.
I guess my question is in line with the previous question, but in terms of in developing countries for chain production industry, what have you seen in terms of best practice or industries that are doing a good job in that field? For example, maquiladoras in Mexico, good practice that are implemented.
Paul, you want to take that?
You would if you could think of one.
Yes, if you could think of one.
Now, are you thinking about company codes of conduct that try to make sure that working conditions are good in the supplier factories that make the clothes and the shoes that are bought here? I mean, those have been very controversial.
What about China's petrochemical company?
Right. Well, I mean, recent studies have shown that these corporate codes of conduct have really not had much impact on improving working conditions in export zones in developing countries. So that's something we need to look a lot more closely at. As long as employees in those developing countries, in those export zones, do not have the right to join a union, do not have the right to join an independent political party and lobby for better wages, their working conditions will not improve much, despite some pressure from multinational corporations on the suppliers. So it's something we really need to look at a lot more closely. I don't have good examples of model situations in that regard.
But there are some NGOs in countries like Nigeria and Korea and other countries that we've described in our ILO report in 2004 that you could get a copy of. There's a really good chapter that summarizes some of these great examples. But the problem is they're all at the local level. They don't all focus on working conditions. And unless there's coalition building, those kinds of initiatives remain at the local level. And they're not trade union based. So if you want, I can give you the reference to the report and you can read about some of those stories.
Please.
Thank you very much for interesting presentations. I was wondering if you know of anyone who's studying the federal workforce, the U.S. federal workforce, either for groups who have gone through the A76 process, which is whereby federal work is outsourced. They have to compete to keep their job, or groups of federal employees who've moved into pay-for-performance systems, which are both large changes just in the last 5 to 10 years.
No, but that may be the problem. There are recent changes, and so there's a lag between the recognition that there may be a problem and the the introduction of research or monitoring. I mean, one point we didn't make is how important we think surveillance of our workplaces and our society is to be aware of what's going on in working people. And there's really no sort of a national surveillance system. I know people get a little uptight about the word surveillance, but basically, monitoring exposures and outcomes, and so knowing where the problems are, what industries these noxious work organizational factors are in, and where all the diseases is building up. I mean, if we were to just simply screen all the workers on a periodic basis, and asked them about their exposures and their outcomes, we would have, pretty easy answer to your question. It's impossible to get money from NIOSH ahead of time for a study, even when you know a law is going to have a completely negative effect. You go in after these things happen and you study them retroactively. I mean, that's how we are, in terms of a culture.
I mean, from what you've heard from people in that workforce, what do they say about these changes?
It's pretty stressful. Truth in advertising, I'm an occupational health physician, worked for the government previously with NIOSH and OSHA. And it is stressful. I'm not in a position to do any measuring or studying. It would be great if somebody else could.
Thank you.
One example that I could give to that, and while not on federal employees, is that University of California, San Francisco took the initiative to assemble a database on all urban bus drivers around the country. There are required exams that bus drivers have to go through to show they're in good health. They cannot have hypertension, or they can't have the Class C license required to drive a bus. But there was no collection of the data around the country. Dr. June Fisher took that initiative on and finally found that I think 40% of all urban bus drivers by age 50, or if they've been on the job for 5 years, are hypertensive.
It's actually 60%.
60% by age 50 are hypertensive.
And there are many commercial drivers who will not treat their diabetes because once they start treating it, they lose their job, according to federal rules.
You
The
can.
gentleman there,
Yes.
we have time for just two more quick questions. The gentleman there
Well,
and the gentleman down
maybe
there.
I have an answer for you. In Sweden, there was a decline in the economy in the early 90s, and a guy called Hugo Westerlund followed several firms to see how the decline affected the employees' health. So you can look at that and we can discuss that later. I'm from Denmark and not US, and I was very surprised, maybe impressed by Josh's presentation of the shortcomings of the US, and so I will. My message should be that stick to Scandinavia.
And there's a gentleman right, I think, in front of you, Kai. Oh, I beg your pardon. I'm getting completely out of order.
I have a
here.
question and a comment.
Then we'll come back to you. and then make that
My
last
question is, if you have research about cultural differences between developed countries and developmental countries, because I'm from Colombia, and we are in a developmental country, and I make a research, and I find that mental health, just you said, has a big outcome with both models, Karasek's model and Sigrid's model too. And I was thinking, if you have thinking a lot of how cultural differences can make a difference in this, because if you have some background, you have some perspective about work, about how work can help you in your life. And it's different if you are grown up in United States or in another kind of country. And this is my question. And my comment is, how about to do an investigation or research about what people thinks about what is the best work for his life? Okay, life satisfaction, we have a level idea, what is it? Why about doing it, right, that kind of research?
But it sounds like in the research you have been doing in Colombia, these job stressors that we've also been looking at affect health in a similar way. So maybe in some jobs those might be more common in one country or another. men and women might differ in the extent of those stressors, but they seem to have an effect on health when they're there, no matter what country they're in. But of course, there are cultural differences in what one might expect from work, but the effect on your health of these stressors seems to be fairly common across many countries.
But maybe thinking in how you can change those things, you have to might think in cultural differences.
Right. Right. Do people think about getting involved in unions to change this, or political parties to change it? To what extent is this possible?
I was thinking that because unions in Colombia have used most of the time, with social purposes, but in a negative way. So employers have a lot of precaution with unions because it's so close related with guerrillas. In that case, they listen to unions and they are alert all the time. So that's not a good way for us. I understand it, but not in a good way. So that's why I asking about cultural differences.
No, I can see where that would be a big obstacle to improving working conditions. Of course, employers in the United States have some similar reactions to unions.
We have the gentleman here with the last question.
Should one of the takeaways from your recommendations be to conclude that you can reduce the 16% of the gross domestic product that's spent on health care at the same time that you can increase gross domestic product overall? Or is that a stretch?
Well, we'd like to think so, all right? We certainly think you can reduce work stressors through these interventions. There's not a big body of literature on intervention studies in the United States, but there are intervention studies, and there are a lot of ways to change the work environment. There aren't as many studies that show that those changes then are reflected in changes in costs. So I can't say to you, gee, yeah, here's the literature, okay, and it's conclusive that making these improvements in the work environment will in fact lead to improved health care. So we have the reverse side of the equation, basically. We know that the bad environments lead to worse health care conditions. We don't really have conclusive evidence that good environments, changing to good environments. That study I showed you, just 2 slides from the New York City worksite blood pressure study, which is sort of the gold standard about looking at work exposures and ambulatory blood pressure, because that study was funded by the NIH for 15 years, and we did 4 years of follow-up, has the only interventions work on job strain and blood pressure. The people who went from being exposed to job strain to not being exposed on follow-up 3 years later, they showed drops in their blood pressure. So we know that there's some degree of reversibility of these psychosocial exposures' impact on the cardiovascular system, okay? So we know that piece of it, I mean, at least some of it. And so it's not unreasonable to think that that would have some long-term impacts on their mental health status and on their productivity at work, but it remains to be demonstrated. Of course, if we wait to demonstrate all these things, years and years will roll by, particularly when we have, in this country, a government that doesn't fund this research for the most part. I mean, NIOSH is decimated.
Well, thank you all for coming. Thank you for some very penetrating questions. Thank you to the panel and to